we're coming to the end and we've slightly gone over time, but if anybody has any questions, please do put your hand up. I have already got a few lined up. I'll go over here. So give the mic to our speakers. Sorry, is that lady? Hello, hello.
Thank you. Hello, hi. Stats on 40% of anorexic girls are on the spectrum. There are similarly quite disproportionate stats on girls who are autistic and trans. What's your specialist knowledge on that area?
Hello, I'm on. I didn't mention the anorexia, but I'm happy to talk of that. I'm no expert. I think that's the first thing to say. But in terms of my experience in schools, there's a terrible term, I think, and we all use it, which is comorbid, and we talk about coexisting, different things. So there's the anorexia. Also, you've got other things, dyslexia, ADHD, etc. But there is a prevalence at the moment. So I work with some families who are, from their perspective, so this isn't my perspective, but they are dealing with double whammy, if you like, because they're dealing with their child as being both having a new diagnosis for ASD, and at the same time they're questioning their gender identity as well. There is a higher prevalence, I believe, so please don't quote me, but certainly within the autistic community there are a lot of people who are not heterosexual. I'm one of them. And I don't know if there's something about being your genuine self. I'm not sure, because there is that thing with me where I can't be anything other than who I am, which can lead to lots of issues in terms of being a little bit blunt sometimes. But yeah, not an expert, but I certainly have noticed certainly in schools, I've had, because we talked, and maybe in my school there were a lot of people who were autistic, there was a lot of talk. We were very open about difference in general. And so what then happens is perhaps people feel more comfortable within those communities of actually being able to talk about difference. And it's like the same thing as saying that that boys, it's a male condition, ASD, but of course actually it's because we're looking through the wrong lens, really. So maybe some of it is that there's just more comfort at the moment in being true to yourself because of the conversations that are being had right now. So yeah, no expert, but...
Thank you, Claire. And I've got a question for Louise. Obviously, slightly controversial, the stuff you were saying, apparently. I suspect this might be a doctor, but if low estrogen increased the risk of dying from COVID-19, then prepubescent children and babies would die at a much higher rate versus older women, and young boys and men would die at much higher rates. The HRT observations have not resulted in strong evidence of a protective effect of HRT. Discuss.
How long have you got? So I'm not here to say that estrogen is the only reason, or low estrogen is the only reason that people die from COVID. Obviously, there are other reasons. We know young people have better immune systems, and that's just because they're younger as well. But as women get older, their immune system works less effectively, especially postmenopausal women who have low estrogen levels. So it's got to be associated, because we know there are other diseases, obviously, that are affected by inflammation. So when we talk about our immune system, it's not just fighting infections. So our cells that fight infections, especially our macrophages, are very either pro-inflammatory. So if they're pro-inflammatory, it can cause disease, such as heart disease, osteoporosis, diabetes, dementia. If they're anti-inflammatory, they keep us well because they fight infections and they reduce the risk of diseases, because heart disease is inflammation in the blood vessels, for example. So if these macrophages, blood cells, are switched on in the wrong way, they'll get pro-inflammatory. And so this is where estrogen is very good. And all those diseases I listed, as if you listen to my lecture, are the same diseases that postmenopausal women get without estrogen. So that's why estrogen is important, but it's not the only reason. The studies looking at HRT, there's hardly been any. There's been no randomized control studies. There's been no studies even looking at giving HRT to people who are ill with COVID. There was a study that was being set up in Stony Brook Hospital because they noticed quite quickly that they had no women on HRT in any of their ITU units. But then they didn't have anybody that could start the study because everyone was scared of HRT because of this whole breast cancer risk. And actually, when I looked at the study, because I spoke to the guys there, another guy there, I spoke to the professor there, and he said that the people that were advising them on the study were gynecologists, and they were going to give a very low dose of a patch, and if you're sweaty, a patch doesn't stick on very well, and they weren't going to do blood tests. It was a really badly set up study. So no one else has done it. We've been trying with Hugh Montgomery here, another man who's a lovely man actually, but he's never seen anyone in an HTU on his ITU beds who's taken HRT. So he said, if I die from COVID, I'm going to come back as a woman taking HRT. That's again not a good study. The study of 17 countries has thousands of people. The study from Oxford that I talked about looked at over 1 million records, GP records, and matched them actually for not just gender, but also for other comorbidities, and found that women taking HRT were less likely to die from COVID. But that's as good as we've got because the studies haven't been done, but the signal is there. I'm very happy to be disproved, but no one I've spoken to can disprove me. I do sound like a demented menopausal woman, which I am, of course.
I want to
Not
say
at
I took
all.
it when I was told not to. Can I just say? Yeah. I want to say that 20 years ago, I thought, I'm okay, I'm not going to be ill, but I don't like the flushes very much. And I went to the doctor, and he went, And then I happened to be going to a sort of evening class with this lovely old doctor, and I said, what about, HRT? And he said, do you need? I said, yes, I do. I think I do. But he said, I've got cancer. And he said, my dear girl, you run around, you look after your children, you seem okay. Does cancer run in your family? No. Well, I'm telling you, you're very small, you're liable to get osteoporosis. This will do you far more good than harm. So go for it, girl. So I took it for 20 years, but after 10 years, I had the doctor call me in, and he said, I think we should take you off. And I said, why? He said, well, we don't know what's going to happen. It could be disastrous in 10 years. I said, you mean I'm going to look like a hag? In 10 years, I'm going to be Dorian Gray. He said, no, well, we just don't know. And I said, I'm feeling good. I think I'll just stay on it. And he didn't want me to stay on it, so I changed doctors.
Good for you. Good for you. Patient consent. Right, just very quickly a question for Margaret. Because of your support group, do you, because you've basically started that support group, you're obviously a very educated woman to have done that. Do you think that the long COVID will be actually, the treatment for it will be better off? Have you got any positive things to say, given that your support group has been going right from the outset?
Could I just start off by saying I didn't start the support group?
Oh, sorry.
And so it's just, there's a very large team that supports that support group. So you can't identify one person and say this person is responsible. It's a very collaborative effort. But I think, yes, we have had influence. And people at NHS England have told us that the reason we have any long COVID clinics, and we can talk about how effective they are, and some of them aren't very effective, but the fact they even exist is because we just wouldn't shut up. And so we are already having influence, and I think there's just this desperation amongst the community of people affected by long COVID that we're just getting forgotten here, and we're going to end up. We know what happened with ME. You know what happens with there are vested interests trying to minimize it, and there are always, I talked a lot about psychogenesis. There's this idea that you're just a bunch of whingers. It's really prevalent, and what's your problem? You didn't die. It's not that bad.
Yeah.
Those ideas are waiting in the wings constantly. So because we've been sort of really fighting against that, and we've been doing an awful lot of work of influencing in various different places, I think we have made a difference. And the fact that the WHO consensus definition is so good is because international patient groups were involved in it. And it would have been, I can absolutely guarantee you, if they hadn't been involved in that, that would have been a very different story. And part of the reason we got involved in it was lots of different groups pushing in different ways and coming to the attention of the WHO.
Thank you. Actually, a very good friend of mine who's very senior in the city, very fit guy, got COVID very badly, and he was off work for 3 months. And I was talking about this whole session we were doing, and he said, "Oh, you'll never guess what, Susie." He's like, "I had it for 3 months. I was so ill, and you know, the GP rang my wife up and said, actually, you know what, he's putting it on. You know, there's nothing wrong with him." And so I said, "Oh, well, hello, welcome to being a woman," because that's what happens to us all the time. So it was quite amazing, and the fact that it just, you know, it is completely being dismissed. But just what, anybody else got one more burning question, and then it's time for a glass of wine, I think.
Hi. Yeah, is it on? Hi, I just wanted to ask, but also explain a little bit of something as well. So I'm a midwife, but I specialise in mental health and substance misuse, and I was diagnosed with ADHD only this year, so in terms of the neurodivergent community, I completely understand. But I sit there in clinic and I see women, and I can tell, I think we just kind of know our people. And usually years of, you know, misdiagnosis or, you know, other mental health issues have come up. And especially the women that will say to me, well, I've been on antidepressants and they don't work. And you look at the history, and obviously I'm not there to diagnose, but it's extremely frustrating because for me, it was life-changing, and every single symptom of it was there, but as a girl, it presents differently. And I'm just wondering, in an institution like the NHS, how can you filter that through? Because it is so... there's such a narrative, like you said, with the whole autistic community, the whole neurodivergent. People look at me and say, how can I have ADHD? I'm not a kid running up and down. They don't know what's going on in my head. But I just feel like if they were to deal with the root, then we would have a lot less issues later on. And I just wonder how you can filter that down in an institution like the NHS, if that makes sense.
I'm not sure I want that question. It's the same, I think, in everywhere. It's not just the NHS, but you're right. You know, if you're already a healthcare organisation, you would actually expect there to be far more understanding of different conditions. But it's the same in education. You would expect people who work in special educational needs schools to have a great understanding of that, and that's not necessarily the case. I think exposure is probably the biggest thing, and it's something that I would invite the press to consider talking about different experiences. And I think, you know, that if you've met one person with autism, you've met one person with autism. It's the same with ADHD. It's the same with Tourette's. I mean, if you talk about Tourette's, what people have to deal with about the public perception of what it means to have Tourette's is crazy, because of course the first thing people think about is, you know, I remember seeing it, I think when I was about 10, John's Not Mad. It was a documentary, and it was, of course, John, Scottish lad who swore. And that's all people think of when they think of Tourette's. And actually, of course, they don't know all the other aspects of it. Just like with ADHD, they don't understand the depressive nature of it for some people, but not for everybody. The fact that it could be a hyperactive or not hyperactive, you know, it's more an attention deficit. You know, so it's about education, but it's about education for people who perhaps are so rooted in what they think they know, not for bad reasons, but for that's what they've taught. And I think I mentioned to a lovely lady who I spoke to in the break, Jade, that actually Maya Angelou is when you know better, do better. And actually, in order for that to happen, we have to communicate that far more widely and explode those myths.
Hi. I agree with everything Claire said, but I think there is something on top of this, that for about the last 20 years that I've known anything about mental health, successive governments, particularly in the last 10, 12 years, have promised to put mental health funding on the same level as physical health. They've promised to put the resources into that, and it just isn't there. They're lying, and it should be brought to the notice. The press should be on it. The media should be on it. We should be applying pressure on this government and any government, but this government in particular, we should be applying pressure for them to put the funds into mental health that it requires, and they know damn well they haven't done it. They're just lying. You look at the facilities. Some of the facilities we had to take Colette to through her life were quite frankly shameful. And for a country of this, with this amount of wealth, to have mental health services like that is a disgrace. And it needs to be, something needs to be done.
Hear, hear. Thanks to all our brilliant speakers. Well said. Thank you. Thanks, everybody.